Hello, I'm Dr. Ken Landau. Thanks for joining us. This is Well Now Doctor. We're going to be discussing atrial fibrillation. Atrial fibrillation refers to an abnormality in the top part of the heart. Those are the chambers that we call the atria. After all, the heart has two sets of chambers. We have the top two, the atria, the bottom two, the ventricles. The heartbeat is generated up in the top part of the heart, actually in an area that we call the sinoatrial node. Sinoatrial node generates electrical impulses that travel down through the junction of the top parts and the bottom parts. Obviously, we call that the atrioventricular junction. And then that stimulates the bottom parts to contract. When the bottom parts contract, hopefully in an organized fashion, then the blood is going to go through the aorta from the left side of the heart, and then it's going to nourish the brain, nourish the heart itself, nourish the lungs and liver and kidneys and muscles. We know on the right-hand side of the heart, the right ventricle contracts and pushes blood into the lungs, travels through the lungs, comes back in the pulmonary veins, and goes into the left side of the heart, the left atria, and then we begin the process all over again. So the blood is flowing, and it requires the coordinated contraction of first the top parts of the heart and then the bottom parts of the heart. And in between the two parts stands a junction, and we call this the atrioventricular junction, where the electricity sort of passes through like a doorway. And in the normal process of events, the heart's going to beat somewhere between about 60 and 80 times a minute, and we're going to have the normal contraction of the top part followed by the bottom part, the lub, dub, lub, dub, that's going to push the blood around in a coordinated fashion. Now, if the blood isn't flowing right, if it isn't flowing correctly, if it's not being pushed by the chambers appropriately, if it's the top part, well, we can probably live with that. It's when the bottom part doesn't function appropriately, the ventricles, then we have all sorts of problems. We need those big muscular ventricles to push the blood into the brain, into the muscles, into the other parts of the body so that we can function. Now, what is atrial fibrillation? Atrial fibrillation is the most common sustained cardiac abnormality that we know of. It's an irregularity of the contraction of the top part of the heart. In fact, the electrical waves come so rapidly that the atria actually can't contract. They can't push the blood into the ventricle. We have the flow normally occurring into the ventricle just because the flow of blood coming back pushes it there. But we need that extra little kick to make sure all of the blood gets down into the bottom of the heart. But it doesn't in this particular condition. We know that the symptoms are variable depending on the individual, depending on the other kind of cardiac abnormalities that a person has, depending on a variety of other factors. We also know that atrial fibrillation does not necessarily, at least at the beginning of the event, have to be permanent. It can occur and then you go back to normal sinus rhythm. It can recur and then go back. We know that characteristically we're talking about a very disorganized, very rapid, very irregular contraction or electrical generation in the top part of the heart. And normally, if we look at the electrocardiogram, in the electrocardiogram, we find that there are distinct and discrete patterns. We call it the P wave, followed by the QRS wave, followed by the T wave, and then we start the process all over again. Well, in this case, the P wave has to do with the atrium, the top part of the heart, contracting. But unfortunately, instead of a regular P wave in atrial fibrillation, the P waves aren't terribly well formed and they're not regular. They're irregularly irregular, and as a result, the bottom part, the contraction of the ventricles, the part that you can feel when you take your pulse, that happens to be irregular too. Now, we know that the ventricles obviously contract the same 60 to 80 times a minute under normal circumstances, but in people who have atrial fibrillation, where the atria actually are producing somewhere around 300 contractions or 300 pulses per minute, Well, the ventricles can't go that fast. If they went that fast, you'd be in ventricular fibrillation, and that's equivalent to having a major heart attack or dying. So that doesn't happen. So what do we know? Well, under normal circumstances, when we have all of these electrical impulses generated by the top part of the heart, under an average circumstance, only somewhere around 120, 160 of them are going to make it through that little junction separating the top part and the bottom part, the part that we call the atrioventricular junction. And because that's going to conceal or not allow some of those waves to get through, the ventricles are only going to be stimulated somewhere between about 120 and 160 times a minute. Now, depending on what happens, if we have a perfectly normal heart, if we have otherwise normal function, if we don't have any other disease present that's going to decrease the activity of that junction, we could theoretically get more than 200 beats a minute. Well, fortunately we don't. With increased vagal tone, increased nervous system tone, the number frequently is considerably less. Oftentimes it can even be normal. Now, there are certain kind of heart diseases, one condition that's known as Wolff-Parkinson-White syndrome, where we can get as many as 300 beats a minute going through, and that obviously is not sustainable. People who have that kind of rate are going to die. Well, we know that atrial fibrillation basically is a disease of adults. It's not present in children. And part of the reason it's not present in children is children don't have any other kind of significant heart disease, and we often need something else abnormal in order to get atrial fibrillation. And not only that, you seem to need a certain size of the atrium. The atrium has to be big enough. You have to have enough muscle. We call that the substrate. There has to be enough substrate in order to get the particular abnormalities, the particular electrical abnormalities that are so frequent in atrial fibrillation. Now, it's important to realize that current costs for atrial fibrillation, well, they're somewhat in excess of $6.5 or $7 billion, and that number is expected to grow about threefold in the next 10, 20, 30 years. We know atrial fibrillation has been around for a long time, but we haven't been talking about it for a long time. It was first hinted at 300 or more years ago when William Harvey, evaluating dying animals, found that there was some chaotic activity of the heart. And that was the first idea, that there was something wrong throughout the 1700s, late 1700s, early 1800s. People got the impression that there were some grossly irregular heartbeats, and they thought that there was something wrong, but they didn't really have a good handle on it until the early 1900s, when Einthoven developed the electrocardiogram, and in about 1909, 1910, the first evidence of atrial fibrillation was detected on an electrocardiogram by Sir Thomas Lewis. Now, it's important to realize that this is an extremely common condition, and one that's becoming more common as time goes on. It's estimated right now that if we look at people less than age 50, somewhere around maybe 0.1% up to maybe about 0.5% of people have atrial fibrillation. But as we look at more senior individuals, say between the ages of 60 and 70, the incidence increases to 2 out of every 100, up to maybe about 4 out of every 100. When we look at people 70 to 80 years old, now we're talking about 5 out of every 100. And if we look at people who are over age 80, and that's the most rapidly growing age group we have, now we're talking about at least 1 person in 10, maybe even as many as 1 in 2, depending on other abnormalities that they may have. So we're talking about significant number of people, and some people estimate that by about the year 2050, 1 in 2 people over age 80, remember the most rapidly increasing age group, are going to suffer from atrial fibrillation. Now, early on, when atrial fibrillation begins, you don't know it. It's very difficult to diagnose. It's not something that is like pneumonia, where you suffer from pneumonia, you go and see the doctor. Well, we know that early on, people who seem to be relatively healthy, when they develop their atrial fibrillation, well, those people are going to have intermittent problems. They're going to have some atrial fibrillation. It might last for a very short period of time, maybe last for moments to hours, and then it'll revert back to normal. Oftentimes, it's totally asymptomatic. People don't even know that they have some sort of underlying cardiac abnormality. It's estimated that probably somewhere between a third and a half of all people who have atrial fibrillation don't even know it. So that means that those numbers that I just quoted to you might actually have to be increased considerably, doubled, because a significant number of people with atrial fibrillation don't even know it. Now, it happens in both men and women. It's a little more frequent in men overall if we look at each individual age group. However, since women live longer, well, overall, the total number of people in the United States with atrial fibrillation, slight increase in those women. We also know that for whatever reason, atrial fibrillation seems to occur much more frequently in the Caucasian population than in the African American population. It's estimated in the United States right now there are somewhere between 2.5 and 5 million people with atrial fibrillation. So a significant number of people. It's estimated in Europe there are about 5 million people, and overall it's estimated that if we go back to just 2000, just the year 2000, well, somewhere around 0.5 to 1% of the population in general suffered from atrial fibrillation. Now, when we look at the numbers in 2015, we find that, well, it's estimated that somewhere between 1 and 2.5% of the population suffer from atrial fibrillation. And it's estimated that in developing countries, because they don't have the same incidence of heart disease that we do, well, it's estimated that in the developing countries, the incidence of atrial fibrillation is like what it used to be in the United States 15, 20, 30, 40 years ago. It was about 0.5%. It's estimated that if we look as far away as 2050, well, it's estimated instead of 5 million people suffering from atrial fibrillation here in the United States, it's probably going to be around 15 million, 16 million people. Significant increase. The likelihood of developing atrial fibrillation, if we look at a 40-year-old individual, and we find over the course of a lifetime, that person probably has as much as a 1 in 4 chance of at some point in time developing atrial fibrillation. Now, it's not uniform throughout the entire population. So if we look at people who are otherwise healthy, people who don't have congestive heart failure, people whose hearts seem to work normal, people who have not had a heart attack, well, even in those people, though the numbers are considerably less, still somewhere around 1 in 6 people are going to develop atrial fibrillation. In China, obviously considerably fewer people, probably an incidence of about 50% of what it is here in the United States. And if we look at the African American population, well, it's probably somewhere about 25% less than the Caucasian population. Well, we know that there are several reasons for an increased incidence of atrial fibrillation. First of all, in the old days, when you had a heart attack, it was not uncommon to die. Nowadays, we save a lot of people. So a lot of people who have significant heart disease are still alive, and as a result, those people are suffering from abnormal structural hearts, and they're at greater risk. And also, obviously, we know that there are a significant number of people who are living a lot longer, but we still know that as many as 1 in 6 people who have atrial fibrillation on relatively close examination are going to be found to be completely normal. Their heart doesn't have any significant problem, and there isn't any reason that we can find for those people suffering from atrial fibrillation, at least according to the standard risk factors. Now, people who have atrial fibrillation, people who have this very fast heart rate, well, they're going to have some consequences. They're going to have a significant number of consequences. So these people are going to have increased utilization of the emergency room, and they're going to have, if they suffer from some heart disease, say they suffer from congestive heart failure, we call it heart failure, people who heart doesn't function appropriately, maybe because they have high blood pressure, maybe because they drank too much alcohol over the course of a lifetime. Well, those people are going to have a greater likelihood not only of having atrial fibrillation, but also having significant complications from the atrial fibrillation. And the atrial fibrillation can make the congestive heart failure worse. And there are about 5 million people in the United States who have congestive heart failure. So we're talking about significant numbers. And when we look at the healthcare costs for these people, it's considerably greater. It's probably about 5-fold increase compared to the normal individual if we have atrial fibrillation. And if you have atrial fibrillation and you have a heart attack, well, you're at greater risk for dying of the heart attack. And by the way, if you have a heart attack, you're at considerably greater risk for having atrial fibrillation. So it goes both ways. And if we look at people who have atrial fibrillation, there's probably at least a 2-fold increase in the likelihood that they're going to die unexpectedly. And when we look at hospitalization, well, hospitalization for atrial fibrillation is equivalent to hospitalization for all other heart disease as far as the arrhythmias are concerned. Well, a significant number of people with atrial fibrillation who are going to develop the condition are going to be hospitalized within the first year or so after having the diagnosis. Going to be admitted to the hospital because they already suffer from congestive heart failure, and now that's going to be made worse because those people need that extra 10% or so of the blood circulating through the system, and atrial fibrillation is going to take it away. We know that these people are much more likely to be hospitalized for some sort of an acute cardiac event, and most scaring, we know that people who have atrial fibrillation are at considerably increased risk for suffering a stroke. And not only do they have an increased incidence of stroke, and we know about the increased incidence of stroke because we hear ads all the time for Xarelto, you should take that one. No, take Pradoxin. No, take Eliquis instead of warfarin, because warfarin has side effects. That's what we hear advertised all the time on the television. So we know that these drugs principally used to treat the increased incidence of stroke in atrial fibrillation. And that's a very real condition, and it's a condition that we'll talk about considerably as we go on. Well, we also know that atrial fibrillation not only comes on because of an abnormal heart, but there are other things. So for instance, if you have surgery in the chest, certainly if you have heart surgery, we know that in the 24 to 48, 72 hours after the heart surgery, atrial fibrillation is extraordinarily common. We know that atrial fibrillation is often associated with other kind of heart disease, cardiac disease, heart failure, or narrowing of the coronary arteries, coronary atherosclerosis, coronary artery disease. And we know probably the most common risk factor for developing atrial fibrillation is heart disease maybe related to hypertension. Now, people who have atrial fibrillation are at considerably greater risk for developing what we call thromboembolic disease. You see, when the heart isn't pumping normally and the blood is stagnant inside the upper chambers, the atria, especially over on the left-hand side, the left atria, and especially in the left atria, we have a little, what we call an appendage, a little finger process or a little extra piece that sort of hangs out. And it's that area that seems to have a lot of slow flow. And in the absence of the normal kind of flow, the blood, just like it does when you cut yourself, it tends to coagulate. And the blood can coagulate inside the heart. And when the blood coagulates inside the heart, if it isn't pasted right up against the heart wall and stays there, but instead gets out into the circulation, then that's what we call an embolism. So we have a thrombus, the clot breaks loose, it's called an embolus, and then the embolus, when we have that blood clot floating around in the system, it's being pushed out by the left ventricle, well, it can go to the brain. So not only do we have thromboembolic disease, but now we have stroke, and because we don't have normal amount of blood circulating through the system, we don't have that little extra push that the top part of the heart adds to the pumping chambers, the bottom part. Well, because of that, we have an increase in congestive heart failure. Now, obviously, we're going to have a decrease in the quality of life. The cost, as we said, is going to increase. We know that a lot of people are going to have disability because of atrial fibrillation. They don't have the energy. They can't get up and about. They seem to be tired all the time. They have a variety of other complications that we'll discuss. And then in addition to that, remember we said that we have some blood clots, and the blood clots are going out. Now, everyone's worried about stroke. A stroke is a major devastating event in many cases, and certainly in association with atrial fibrillation, the incidence and the severity of stroke seems to be considerably greater than in stroke for other reasons. Well, in addition to all of that, we have some little embolic phenomena. We have not those big massive clots, but we have little tiny ones, and the tiny ones can go to the brain too. Now, we don't have demonstrable stroke. We don't suffer from the lack of use of an arm or the problem with our memory, at least acutely. But over a period of time, those little tiny microstrokes or transient ischemic attacks can lead to significant cognitive function. And if you have significant cognitive function, you can't function normally. And then, of course, people can be absent from work. Now, additionally, we know that people who have the strokes associated with atrial fibrillation, because atrial fibrillation can be ongoing, you don't even know necessarily that you're suffering from the condition because you might not have any other kind of symptoms, but we know that the stroke oftentimes happens to be recurrent. Well, in addition to that, we know that the episodes of atrial fibrillation are recurrent. And not only are they recurrent, but we know that because they come and go, at least early on, we know that it's very difficult to make the diagnosis. So if we look at the time from onset of atrial fibrillation to the time the doctor makes a diagnosis, it oftentimes is around 4 years. That would be the average. If we look at the people who have the diagnosis made within a year after the first developments, it's estimated that it's only about 1 in 8 of those people who have the atrial fibrillation. And if we look at a period of 5 to 10 years to make the diagnosis, probably about a third of the people takes that long. And if we look at a period of over 10 years, probably somewhere around 1 in 5 people with atrial fibrillation take that long. Now, as I said before, we know that a lot of people are surviving. We're doing a lot more heart surgery. We're using a lot more drugs. And as a result, people are not dying with the same incidence they did of heart disease 20, 30 years ago. We know that the incidence of smoking is considerably reduced. So a lot of people surviving, a lot of people getting older. And both of these, the increased incidence of survival and the increased incidence or the decreased incidence of some bad things happening like the cigarette smoking, well, that's caused greater aging in the population, greater aging, greater risk. And we also know that we doctors are more attuned to making the diagnosis. It's sort of a popular diagnosis nowadays. And as a matter of fact, some people are even talking about that there might be several different types of atrial fibrillation, that maybe atrial fibrillation is just sort of a common chronic end-stage disease, sort of like cirrhosis of the liver. You can get cirrhosis of the liver because you drink too much alcohol, because you maybe have used intravenous drugs, maybe you had hepatitis, maybe you took too many prescription kind of drugs that affected the liver, maybe you have some other kind of problem with the liver. All of those lead to cirrhosis. Doesn't matter what the cause is, you end up with cirrhosis. Well, it's so too perhaps the case with atrial fibrillation that a variety of different kind of diseases can result in what we call the end-stage disease, or atrial fibrillation. Now, how do we define the condition? Well, it's defined by a variety of conditions. We know the European Society of Cardiology defines it as a cardiac arrhythmia, we know that, without those P waves that we talked about, the abnormality of the distinct P waves. And it seems that the electrical activity has to stimulate the rate anywhere between, say, about 200 and more than 300 beats a minute, or 300 impulses per minute. Now we know that there's a problem with rapid rate. especially if that rapid rate happens to affect the ventricle. So we can do some studies where we can actually put a pacemaker in and just pace the heart at a very fast rate. And if we pace the heart at a very fast rate, we know that we're going to cause the contractions to be so fast that they can't pump enough blood into the coronary arteries. Now think of that for a moment. If we pump the heart so fast, if we cause so many contractions, there isn't enough time for the blood to flow inside the coronary arteries, because when the heart's contracting, it's stopping the flow. You only have flow through the coronary arteries when the heart is in the resting phase. And in addition, not only do we have less flow into the heart that nourishes the heart muscle, of course, and the faster the heart is beating, the more nourishment it gets, but the less we're giving it. Not only that, but we also have significant problems when we pace the heart at a very fast rate, or when the heart goes fast just for whatever reason. We also know that there are going to be some abnormalities that are going to occur in the coronary arteries themselves, some microcirculatory changes, and those microcirculatory changes are going to significantly impair the heart's ability to function. Well, what causes atrial fibrillation? It's tough to say. We know that we can divide atrial fibrillation into two different subcategories. Very popular subcategories are valvular and nonvalvular. So when you listen to those ads for Xarelto and Pradaxa and Eliquis, you hear them say, well, these drugs are not for people who have valvular heart disease. So in the old days, we used to have a very common condition, rheumatic heart disease. Rheumatic heart disease would frequently affect the mitral valve. Well, it seems the mitral valve is just in the same area where the generation of the impulses for atrial fibrillation originate. And those people who have abnormalities of the mitral valve, valvular atrial fibrillation, seem to be at considerably greater risk than people with non-valvular disease. Well, what's the incidence in stroke? If you have valvular heart disease, it's extraordinarily high. Well, it might be as much as 1,000 to 2,000% greater than it is in normal individuals. And if we look at people who have non-valvular heart disease, that's the most common group. That's the group that ends up because you had high blood pressure, or maybe because you have congestive heart failure, or you have some other kind of abnormality, you've suffered a heart attack. Well, in that group, the incidence of strokes probably increased by about 5-fold considered versus normal. Now, it doesn't have to be that you have heart disease. You could have some other kind of secondary disease that can lead to atrial fibrillation. There are lots of secondary heart diseases or secondary conditions. For instance, it could be your thyroid, or it could be you drank too much alcohol, or if you're a young person, maybe you just exercised too much. Yes, indeed, exercising too much can lead to some abnormalities of the heart that can predispose to atrial fibrillation. Now, we also know that there's another condition, and it probably is something on the road to atrial fibrillation. We call it atrial flutter. Atrial flutter occurs when we have the distinct P waves. They're still present, we can see them. And as a matter of fact, in this condition, we have more of the waves getting through that door that we call the atrial ventricular junction. More of the impulses get through because there are not as many that are concealed because one bumps into another and pushes it out of the way. Well, in this case, we're going to have a very fast ventricular rate, and that can cause significant other kinds of problems. Fortunately, at least for people who have atrial flutter, well, given enough time, they might develop atrial fibrillation. We can treat that easier with our medicines. But at least for people with atrial flutter, maybe they're more likely to respond to that ablation therapy, the atrial ablation that you hear so much talk about. Well, let's talk about what causes atrial fibrillation. Now, we know there are a lot of causes of atrial fibrillation. We have some well-defined events, like your thyroid becomes abnormal. You start putting out too much thyroid hormone. You are hyperthyroid. Well, we know President Bush, the elder, when he was president, he developed atrial fibrillation, and the cause of his atrial fibrillation was hyperthyroidism. Treat the hyperthyroidism, atrial fibrillation goes away. Well, that's good. And we know that maybe you get atrial fibrillation because you drink too much alcohol. If you drink too much alcohol, well, that can precipitate atrial fibrillation. So stay away from alcohol if you happen to suffer from that, or drink moderate amounts. And then we know that you can have some nervous system abnormalities. Your adrenaline could be too high. Or, on the other hand, you could make too much activity in a different part of the nervous system. We call it the parasympathetic nervous system, the vagus nerve. And if that's stimulated enough, then we know that that increases your risk for developing atrial fibrillation. And then, of course, we mentioned surgery. Surgery, well, certainly surgery on the heart or surgery on the chest, but also surgery in the belly or surgery on the blood vessels can lead to an increased incidence of atrial fibrillation, in part because of the stimulation of the nervous system and in part due to direct mechanical irritation. Now, we know that if the pressure inside the atrium, inside the left atrium especially, is increased, we know that that can lead to problems. Well, if your bottom part of the heart isn't functioning normally because you had a heart attack and now you have some scar tissue, or maybe because you've had some other kind of an abnormality, maybe you've had high blood pressure for too long a period of time, maybe you smoked cigarettes for too long a period of time, well, the top part of the heart, the atria, has to contract more forcefully to try to push the blood into the ventricles, and then it just kind of poops out over a period of time. It gets larger, and larger muscle, stretched muscle, seems to increase the incidence of atrial fibrillation. And we also know that leads to a change in the balance of the nervous system I was just telling you about a moment ago. The autonomic nervous system, either a combination of too much of the sympathetic tone, the adrenaline, or too much of the other, the vagus tone. We know also that it can be triggered by certain genetic factors. Now, the genetic factors are extraordinarily important, and as a matter of fact, it may well be that a significant number of people require some sort of a genetic abnormality in order to develop atrial fibrillation, because after all, most people with high blood pressure are not going to develop the condition. Most people who have heart attacks are not going to develop the condition. So what's the extra edge that pushes some people over the line? Well, it might be a genetic proclivity, a genetic predisposition. Now, we know the most common causes: coronary artery disease, high blood pressure, valve problems, problem with the muscle of the heart itself, or just coronary heart disease. And then we have the associated events or associated problems. So we have high blood pressure, probably in about 50% of the cases of atrial fibrillation, or diabetes can cause the similar kind of a problem, an increased incidence, and congestive heart failure, as we mentioned, even kidney failure, or just a decrease in the kidney function associated with the aging process. And for those people who smoke cigarettes, we know that chronic obstructive lung disease, COPD, the emphysema, the bronchitis, can dramatically increase the incidence of atrial fibrillation. Stroke can increase the incidence, and so too can certain other cognitive problems increase the incidence. Obesity itself, well, obesity, just think about it. Obese people have miles and miles and miles. Some people estimate that each pound you have in excess of normal might increase the number of capillaries by about 5 miles. So the heart has to pump one heck of a lot harder in obese people than it does in thin people. If it is going to pump more forcefully to get the blood through all of those extra miles of vasculature, you can see that that's going to potentially increase the amount of thickness in the bottom chamber. Well, if you have an increased thickness in the bottom chamber, the top chamber is going to have a harder time pushing blood into it. And as a matter of fact, in addition, we'll talk about that later, we have infiltration of fat, just like we have infiltration of fat around the liver. Probably one of the most common causes of cirrhosis right now is non-alcoholic steatohepatitis, where we just have too many fat cells. And it used to be thought that the fat cells were inactive. Fat cells didn't do anything, just stored energy and sat around and did nothing. Well, now we know that's not true. Fat cells are metabolically active, and some of the metabolic products of fat cells are very bad for people. And just as fat people get accumulation of fat inside the liver, that causes the liver not to function very well. Now we're learning that fat people get infiltration of fat inside the heart, actually inside the heart itself, in between the muscle cells, and that prevents the heart from functioning normally, and that's part of the reason that people who are obese, people who are fat, seem to have an increased incidence of problems. And so too, if you have a lung problem, well, we already talked about the chronic obstructive lung disease, the emphysema and the bronchitis, but people who have pulmonary emboli, people who have clots that come from the leg and they shoot up into the lung, well, those people seem to have an increased incidence of atrial fibrillation. So too, the thyroid, and the thyroid problem doesn't have to be something that's easily diagnosed. You might not have any symptoms of an excess amount of thyroid hormone. We might discover that only on a simple blood test. Alcohol story, we said, is dose dependent, and of course in younger individuals, we know that the more you exercise, especially if you exercise very heavily, the greater your risk is going to be. But after all, when we look at all of the people who have atrial fibrillation, we find, at least among younger people, a significant percentage of those are not going to have any identifiable cause. Now that's very important. And it's important that we investigate those individuals and we do all sorts of evaluations for problems. We study them with the electrocardiograms, maybe we do a stress test, maybe we do some echocardiogram, and we can't find any structural heart-related disease. Now, in most people, yes, indeed, we're going to find the heart attack, or we're going to find some incidence of coronary surgery that might be the precipitating factor, or we're going to find the pulmonary disease or something like that. On the other hand, a significant number of people who develop atrial fibrillation, especially when they're relatively young, we're not going to be able to find any abnormality, although there are certain things that seem to develop that are increasing our suspicion. So, for instance, those people who have obstructive sleep apnea, well, that seems to be a problem that's increasing in frequency nowadays, and simply the aging process. But remember, somewhere 20%, 30, 40, 50% of the people, at least early on, are not going to have any acute definable causes for their atrial fibrillation. Now, we'll take a break, we'll be back, and then we'll talk about some of the specific pathophysiology, why people develop it, what is atrial fibrillation, and then, of course, as we go on, we'll discuss how we make the diagnosis, how we treat the disease, how we treat the rate abnormality, the rhythm abnormality, and then what do we do with the increased incidence of stroke? What about those drugs that we hear so much about, the Pradaxa, the Xarelto, and the Eliquis, and then, of course, the warfarin? And then, as a matter of fact, what about the ablation therapy? What makes sense? We'll be back and tell you that later. Thanks for watching. I'm Dr. Ken Landau.